Good morning, everybody. Let's start our CNS 5 Viva session. Candidate 1, request control, please.
Okay.
This is, I think, this first one. 1 second. 1 second, doctor. 1 second, sorry. Yes, this is a 2-year-old female patient presented with seizures and headache. Go on.
Okay, so I'm presented with MRI of the brain for a 2 years old child with seizures and headache.
Sorry, 1 second. 1 second. 1 second. What's happening? Okay. Okay, leave the mouse, doctor, please. Leave the mouse.
Okay.
I don't know what happened. This is not the case. Okay, this is the case. Again. Again.
Okay.
Go on.
Okay, so I'm trying to scroll. I think I'm moving the screen, the whole screen by the mouse.
Oh, leave the mouse. We lost this case.
Okay.
By the way.
Okay. Okay.
lost خلاص. Because this the answer was shown. خلاص. I will scroll.
Okay.
Will scroll because it looks like some problem. Can you
Okay, fine.
Yes. Again, 55-year-old male patient presented with weakness.
Okay, so I'm presented with MRI of the spine for 55-year-old male presenting with weakness. I would like to have a general look before starting my comments. So this is T1. It shows an abnormal region in the craniocervical junction of the cord. It is expanding the cord with heterogeneous iso-intense signal to the cord and the brain material. So it is showing slight internal areas of hypointensity. There is no definitive extra dural extension in this image. The bone marrow signal appears slightly altered in the adjacent vertebrae. No abnormal high signal to suggest internal bleeding or fat. I would like to check the other sequences. I would like to check the T2 post-contrast and the axial. So on the T2, the lesion is heterogeneously hyper-intense with intrinsic area of increased intensity associated with adjacent abnormal high signal regions. I would like to check the contrast, post-contrast study, please. Okay, this is the cervical dorsolateral region. No additional similar abnormality in this segment.
Yes. This is axial.
Yes, okay. So the lesion is intradural, intramedullary, heterogeneous, with peripheral enhancement. So I would like to check the ADC and the diffusion.
Not available. What's your diagnosis?
Okay, so axial lesions in the upper cord with these appearances are either ependymoma or astrocytomas. Other possibilities could be metastasis from brain lesions. So I would like to correlate to the patient's history. I would like to check for the brain and the rest. I saw the rest of the spine. There is no additional lesions. So I would like to check for the brain for any associated brain masses. These patients need to be urgently referred to the neurosurgical team for biopsy and histopathology.
In your opinion, in this age group, what is the most common differential diagnosis?
Okay, ependymoma is accepted.
Are you sure?
It's okay. So astrocytoma.
Are you sure?
Okay,
Which one is more,
metastasis.
which one is more common? Could you think this is could be metastasis. Look again. All of
Okay,
this.
it is intraaxial. It is
Yes.
intraaxial. It is less likely to be metastasis.
So in this age group.
Okay, being heterogeneous with multiple cystic areas.
Mhm.
Okay, this is most in favor of ependymoma. It contains calcification, hemorrhage, cystic
What
changes,
is your
and
next step?
expand along the foramina.
What is your next step?
Okay, so I will do MRI of the brain, looking for any other associated lesion,
What else?
and refer the patient urgently.
What else?
Spectroscopy?
What else? What
Not
else?
sure.
Okay, I will help you how to rule out any metastasis from this lesion.
Okay, I will check the rest of the spine
Which is
and the
which sequence do you want?
okay post contrast lumbosacral region. Yes, there are abnormal enhancing lesions seen in the most caudal segment of the cord.
So
Suspicious of metastasis.
suspicious
So
or
drop
sure? One
metastasis.
second, 1 second. This is suspicious or sure sign. Look, what do you think?
Yes, sure.
So what's your final diagnosis? Hello?
Okay, yes, ependymoma.
With complicated by.
Drop metastasis.
Okay. What is the name of this drop metastasis?
Okay, it's not typical for the sugary cords.
Okay. Eh, What else? I'm not talking about the sign. What is the name of metastasis here?
I
Look,
couldn't recall.
drop
Mhm.
metastasis. Drop dural metastasis.
Okay.
Despite the age group is adult patient, and the most common in adult patient in the spinal cord is ependymoma, like you said. You are right, by the way, but pathologically it was proven as pilocytic astrocytoma. Okay, the tricky point here, my colleague, thank you, Dr. Nagam, so much. You did very well.
Okay, welcome. Thank you for you.
Welcome. The tricky point here, this is an easy, very easy, very obvious here. Leave the mouse, Dr. Nagam, please. Leave. Very easy to pick up here. And I advise you many times, don't trust the examiner when he presented something very obvious, except the starting case. The starting case almost is something very mild, and يعني, don't worry, he will give you something almost very clear to start up. But after the first case, you should be in doubt if he give you something obvious like this, like this. So you must squeeze your brain. In this case, what is behind? This is tumor. So this is not infarction. If infarction, search for cause like dissection, vasculitis. Okay, but in an easy case like this or an obvious tumor like this, search for metastasis. Your doubt must be directed towards the complication, metastasis here. Okay, you talk about the vertebrae, but this is not the most common site of metastasis here. Ependymoma or pilocytic astrocytoma may metastasize trans CSF, drop metastasis. So your next examination, you told me, Dr. Nam, I will do brain. Do you think the CSF will go up or down? Down. So the most common drop metastasis will be down. So we must examine the whole spine. Okay. Here, this is the dorsolumbar. I think nothing obvious. But here, very obvious. And when you have a tumor in the in the upper cord, the cervical cord, and then you have something enhancing here. Don't tell the examiner it is highly suspicious. No, it is a metastasis until proof otherwise. Okay, my colleagues, is it clear?
Okay.
So,
Yes.
so in in every case, search especially easy cases. Search what behind that. If the case is very obvious, or the pathology is very obvious, and this is not the startup case, it must there must be something tricky. Okay. Thank you so much. Next candidate.
Yes, sir.
Hello, doctor.
Hello.
Yes, welcome. This is 20-year-old female patient presented with dystonia, and the tremors. Okay.
Okay. Can you scroll for me? Yes.
Yes, yes.
Okay, I'm presenting here with axial T2 MRI brain. Okay.
Stop me at the slice of interest for you.
Okay. Here.
Okay.
Again, okay, I can appreciate there is bilateral thalamic swelling could be identified, which shows low T2 low T2 signal intensity. There is compressing the third ventricle, leading to upstream ventricular dilatation of lateral ventricles. Okay. I can't see. Okay. Can I see the T1 and flare sequences? Okay, the same lesion here show high flare signal intensity. Actually, the lesions affects the bilateral thalamic and also bilateral caudate, bilateral lentiform nucleus also show high signal intensity. I can I see the T1 also?
1 second. Is that better to describe the abnormality here as signal abnormality or lesion?
I see a signal abnormality. It appears as a systemic condition, not
Okay.
MS.
Because lesion, you give an impression to the examiner as a local lesion, focal lesion.
Yeah.
Okay.
Yes.
So, okay, go on.
تمام. Okay. I'm checking the brainstem. There's no other there's no other signal abnormality. So there is bilateral basal ganglia and thalamic abnormal signal intensity displaying a high flare signal intensity and low and also the midbrain. There is also a signal abnormality. Can I check the diffusion if there is any diffusion restriction? Okay. There's okay, no diffusion, no obvious diffusion. Can I see the ADC?
1 second.
Okay. There's no diffusion restriction, no obvious diffusion restriction, I
What's your
think.
diagnosis?
So my differential diagnosis will be as regards bilateral thalamic and basal ganglionic high flare signal intensity. It will be either maybe it's a systemic condition like uremia or hepatic encephalopathy or there may be maybe infarctions also, but the infarctions there is no diffusion restriction, so it's excluded. So or hypoglycemia.
What else?
Um,
Look at this slide.
maybe
The answer in this slice. What do you think?
okay, um, as they regard the affection of the midbrain also. Um, I mean,
Mm-hmm.
I'm not sure. Maybe some toxin poisoning
Okay.
or carbon monoxide poisoning.
What is the name of the
Um,
sign?
um, I don't know. I'm not
Remember,
sure.
remember, and I will help you. Hmm.
Um, is some panda eye sign, but no.
What does it mean?
Uh,
Yes, yes. What does it mean for you?
panda eye sign. I think um, it's. I didn't remember.
Yes, yes. Something metabolic and band with panda eye sign.
Yes. Wilson.
Yes,
Jane.
yes,
Wilson disease.
yes. This is the panda eye sign, my colleagues. This is the panda,
Yeah.
and this is the giant panda. There are two panda sign in the Wilson disease. One is giant panda in the midbrain, and one is the mini panda in the bones. At least there are one or two panda in Wilson disease. Okay, look,
Okay.
eyes, dark eyes, and this white face, and check white face and check. Okay, and this ear. Okay, let's see our
Okay.
let's see our case. What happened? The same, exactly here. See,
Yeah. Yeah.
the same.
Yeah.
What happened here?
Panda eye sign.
What happened here? There are some abnormality in the basal ganglia and the thalamus. If
Yeah.
I am in your position during the exam, I will not remember which type of metabolic disease. Is it uremia? Is it encephalopathy? So I will search for any characteristic sign. Number one, go to the midbrain. If you find this banda, like this, you smash this the case. This is Wilson disease. If you didn't find, search for another, the distribution at least. Why? Because Wilson disease, this is the basal ganglia, consisted of this nucleus and lentiform nucleus. Wilson love the outer part. Okay,
Okay.
globus pallidus.
The
He likes this
glutamine.
butamin. Oh, okay. This butamin, the outer part here and here. Okay. He likes this, and then he will go to this one. What is this? The midbrain. He will cause a pathologic characteristic pathological sign called Banda sign. Okay. This is number one.
Okay.
Number two, when you find a systemic disease, يعني bilateral, symmetric like this, you should think about metabolic or systemic disease. So it is very difficult and very, very rare to talk about the infarction. Okay? Very difficult.
Okay.
Don't talk, how could this one to be an infarction, especially it has no special territorial distribution. Okay?
Yes.
Okay, so the most
Okay.
important here to diagnose Wilson is this panda sign. Thank you, doctor, so much. It was
Thank you. Thank you.
Wilson disease. It was a Wilson disease. Wilson disease, like too much the basal ganglia, especially the butamen. In Arabic language, butamen we called barra. Barra means out, the outer part of the lentiform nucleus. Okay, this is the outer part because we have outer part butamen and inner part globus pallidus. Thank you so much, doctor. Cerebroplasmin carrier deficiency is the main cause of Wilson disease. It also may be associated with liver parenchymal disease up to liver cirrhosis. Next candidate.
Good afternoon, sir.
Good afternoon. 5-year-old male patient presented with headache and progressive vision loss. Go on.
Okay, so I've been presented with sagittal T1 brain images of a 4 years old male patient who have been presented with vision loss. So here I can see that there is significant dilatation of the ventricles with upward bowing of the corpus callosum. I can see that there is intermediate to low intensity area is seen, which is present in the suprasellar region. It is showing septations in it. I can see septum pellucidum cavum. And there is also heterogeneous area is seen, which is involving the cella. So there are also few heterogeneously intense foci are seen within this lesion. So I'm trying to look for the presence of, as I can see, there's significant dilatation of the temporal horns, posterior horns, and however, the fourth ventricles appears. Fourth ventricles appears normal. May I request the remote control, sir?
I will scroll for you to save our time. What do you think?
Okay.
What do you want?
Okay, so fourth ventricles appear normal. So I'm thinking that there is obstruction at the level of the suprasellar region, which is causing obstruction. So in my routine practice, I'll also check the post-contrast images. So on post-contrast images, there is only enhancement of the septations with non-enhancing central areas. And there is also slight enhancement of the infundibulum, but I cannot find any enhancement on the cellar region. So in summary, the findings are of suprasellar mass, which is predominantly cystic, with only septal enhancement. So my differential in this case, this could be a craniopharyngioma, as the patient is 4 years old. I will also check T2 images to look for the presence of optic chiasm. Just to comment on the optic chiasm, as the patient have.
What is your next step?
So I immediately convey the finding to the referring physician, as the patient had obstructive hydrocephalus, which is causing patient optic chiasm symptoms. And loss of vision. So immediate drainage after neurosurgical team consultation is suggested in this case for relief of obstruction.
Yes. Do you have any warning sign here in these slides?
Yeah, there is a transependymal seepage of the
What does it
due to
mean?
acute obstruction.
Yeah. What does
Pardon?
What does it mean?
So this is an acute dilatation of the lateral ventricles and third ventricle, which is causing obstructive hydrocephalus.
Okay. Why this cyst, despite you mentioned this is cyst, but in T1 it looks like iso intense or hyper intense to the CSF. And and also this
Okay,
name.
yeah.
Why? Why do you
Yeah.
think?
So this is iso to the gray matter. So this may be non-enhancing
Yes, enhancing. Why?
soft tissue. Yeah. So
And
this can be proteinaceous material in it, so that's why
Right.
it's not CSF.
It has a characteristic name. Do you remember it?
Uh,
In
no,
in
no, I don't
craniopharyngioma.
think so.
In craniopharyngioma. Very characteristic name.
I cannot recall right now.
Okay, thank you, doctor. You did very well.
Thank you.
It is slightly difficult. Why? Because it looks like centered on the lateral ventricle. Look here, my colleague. Even here, in this coronal one, really looks like something from the third ventricle. Okay? But if you concentrate more and more, you will find some soft tissue here. Here, look. Down. This one. Supracellular enhancing, nodular enhancing soft tissue. Here, this is one. Besides this septi. Besides this one, okay? Number two,
Yeah.
cyst itself is not fluid containing, is not a watery cyst. It is iso. Big contrast or big difference between the CSF and the cyst. So it looks like contains some high density proteinaceous motor oil content. Okay, this is
Okay.
the unique name of the content in craniopharyngioma. I think this one, this is hyper
Okay.
T1 signal intensity, very suggestive of craniopharyngioma. Okay, the most
Okay.
important
Thank
here,
you.
welcome. The most important here to save the patient because his hydrocephalus is under high pressure. This is not acute, by the way, doctor. This is not acute. Acute means something within few hours, 24 hours even. But it means his hydrocephalus is under high pressure up to
Okay.
the
Yeah.
CSF exit from the ependymal surface. So we call this one transependymal CSF permeation. So the exact description here is CSF, transependymal CSF permeation due to high pressure hydrocephalus. Okay. First thing to be done is to insert immediate insertion of ventriculoperitoneal shunt to relieve this severe hydrocephalus to save the brain. Second, transferring to a pediatric neurosurgeon. Okay, thank you, doctor, so much. Next candidate.
Good afternoon.
Good afternoon. Doctor, this is 10-year-old male patient presented with a headache.
Okay. I'm presented with the axial MR T1 weighted image of a 10-year-old patient who is presented with headache. I can appreciate there is a large iso-intensilobular mass iso to the gray matter in the lateral ventricle. I think predominantly on the right side with the with significant high dilatation of the ventricle system, and it is showing some areas of low signal intensity as well. So it has stopped scrolling. It has stopped scrolling. Yeah. Yeah, there is also dilated. Third ventricle is also dilated, and yes, if I can look at this T2 or post contrast image to further characterize this. Yes, on this T2 image is this large lobulated lesion is showing multiple areas, small cystic areas which are appearing hyper intense on this T2 image, and rest of the findings I think remains the same. there is a significant extraventricular transependymal seepage of CSF, also appreciated along the lateral ventricles, predominantly on the frontal horn as well as along the posterior horn as well.
Okay, what's your diagnosis?
Yeah, yeah. In a child, this I would like in a child, I think my first differential would include a choroid plexus papilloma, as I cannot appreciate any parenchymal invasion of this lesion. It is intraventricular, so choroid plexus carcinoma is less likely. However, I can appreciate there are certain other areas of similar signal intensity appearing in the right frontal lobe.
Okay.
This it is into the right frontal horn, and I would like to look at the sagittal imaging if available to confirm the extension of this mass. Um, it is causing significant mass effect uh, on the cerebellum posteriorly.
Where
Uh,
where does this lesion centered?
um, yeah,
Are you sure this is
this is
intraventricular?
uh, this uh, it is I mean it is raising the this tentorium cerebelli superiorly. It is displayed superiorly.
No.
It is causing
Look, this is the
my
tentorium. This is the
mm,
tentorium.
yeah, and the cerebellum is
Yes.
also looking abnormal. And I think this is tactile plate, which I
Okay.
can't appreciate on this sagittal image.
So it is
I can't
mainly
appreciate the
centered
tactile
on.
plate.
It is mainly
Mainly, it seems to be rising from the tactile plate.
okay. So it is
Mm.
intraventricular or extra axial.
Yeah, I actually thought at first impression was that it is intraventricular,
Okay,
but
okay.
now
But
intraventric.
you lately ask for MBR.
Yes,
Mhm.
yes, because I was confused about
No
this
problem.
origin of the
No problem. So
mass. And intraventricular mass can not cause mass effect on the cerebellum like this.
yes.
So yeah, this seems to be extraventricular mass. Uh, and also it is causing, I think it's the hydrocephalus is due to obstruction at the level of maybe aqueduct, uh, and as fourth ventricle is not dilated, but there is proximal upstream dilatation of the ventricle system. There's a large heterogeneously enhancing mass with central non-enhancing component. I think the origin of mass
Look
is,
here.
yeah,
What happened?
it's, um, some of the areas are showing uh, a low signal or blooming artifact.
What does it mean for you?
On the
For
GRE, it is
lesion,
showing
for a lesion
hemorrhage.
in this region.
Hmm. Tactile plate gliomas are
What
usually
else? What do you think gliomas will have a blooming artifact? What else?
yeah, this
What
is
else
what
in
I was
this
don't know.
region?
They don't have usually. They can be. I mean, they're slow growing and they cause bulges and all that. But this blooming artifact is due to hemorrhagic component within this lesion. This
Could you pick up
mm,
well the splenium?
splenium, it is infiltrated,
Yes.
I think.
What does it mean for you?
Yes.
If a tectal plate glioma,
Yeah.
if this
Yeah.
lesion is a tectal plate glioma, it
Yeah.
is possible to go up, and then infiltrate here. or it is something else. See, look here. Look here.
The brainstem is quite distorted as well due
Okay,
to this
but
massive.
where is the main center? Where is the main center? See, this is the
Leak.
vein of Galen. This is
Okay.
both internal cerebral veins. Why the veins are markedly displayed and infiltrated,
So,
something like this? Why? What does it mean for you? I think
okay.
there are
So it's
very better. Yeah, tell me. What does it mean for you?
means it can be pineal origin mass.
Yes, yes.
Yes, yes.
Any
Pineal origin mass.
see
Yeah.
the veins. See the veins. Any
Yes.
lesion that displaying the both internal cerebral veins, think about biennial origin. Okay? Again, my colleague.
Okay.
Okay?
Yes.
By the way, it is very difficult. Next, what does this blooming artifact mean in a biennial region?
Blooming, it signifies a hemorrhage or calcification can also.
In 10 years old, what's your final diagnosis?
A germinoma should be first.
What
Second
else?
can be blastoma, pineoblastoma.
What is your next step?
And next step is urgently inform findings to the clinical team, refer the case to the pediatric neurosurgical team. Firstly, they have to, relieve this pressure hydrocephalus
Okay, what
for
else?
with the
What should you
shunting, and
exclude?
then
What should you exclude?
and would also like to image the neural axis for the drop metastasis.
Okay.
Whole of the spine should be images.
And what is this?
And these are, yeah, this was a similar lesion, maybe met in the cortex.
Yes.
It's
Myths
a
or
metastatic
component.
deposit in the cortex.
Oh,
And we should we also suggest a CT to see any calcification?
yes. See, my colleague,
Lesion?
thank you,
Yes.
doctor, so much.
Yeah.
In any lesions
Yes.
like this, in axial, it is very difficult really to know the exact site. I will give you very simple advice. Look at the brain stem and see, is this large lesion anterior or posterior? If it is anterior, like the case before, so we are talking about something supracellular. If it is posterior like this, so we have a big doubt, a big doubt. See, this is a brain stem or midbrain, go up. This is posterior, okay?
Yes.
So we have a big doubt of a biennial origin. What is our next step? Either to pick up here, especially in the contrast, the internal cerebral veins. Look here, it is markedly displayed. So this is the origin from biennial or from the sagittal. Here, it is from the biennial region or tectal plate, or maybe something else from the cerebellum. But look here, the fourth ventricle is intact. This
Yes.
lesion is outside. Okay,
So
somebody.
how to differentiate a tactile plate and pineal?
Yeah, great. I'm talking generally. Dr. Akila, you
Okay.
did very well, by the way. It is very difficult case. I'm trying to present many atypical cases. Okay.
Yeah.
It may be medulloblastoma, but medulloblastoma should enlarge and expand the fourth ventricle. So we
Yes.
are outside the fourth ventricle. We are outside the other ventricular system. We are in this region. So it is very good to describe this lesion as tectal lesion or biennial region. Okay?
Right.
But
Right.
in gradient, this blooming artifact almost indicate calcification. So we are thinking about this region. We are thinking about lesion with calcification or blooming artifact. So it is a pineal origin. Okay. So we are thinking in myeloblastomoma, germinoma like this. Thank you, doctor, so much. The
Thank
lesion
you.
was a benyloblastoma, especially the patient is so young. Thank you. Next candidate.
Hello, sir.
Welcome. This 13-year-old female patient presented with headache.
So these are MR T2 weighted images, axial sections. There are multifocal hyperintense signals are seen involving the predominantly involving the bilateral thalami and the basal ganglia. It is causing mild expansion of the thalami. I would like to see the other images. There is also a hyperintense foci seen in the right periventricular location. I would like to see the, okay, these are flare images. Abnormal signals abnormal hyperintense signals are also seen involving the midbrain. I think, can you go to the region? Yeah.
The patient
Midbrain view
have
hyperintensity,
the patient has acute headache. Go on.
acute headache. Okay. So few hyperintensity is also seen involving the midbrain and the, I think it's a pons area.
What?
I think there is hyperintense signals in the pons.
Yes.
Yeah, this. Okay, and few hyperintensities. Okay. Other than that, there is no hydrograph seen. There are no other cortical or I sir, I would also like to see the sagittal images. To comment on the it's okay. So on Excel images, I can appreciate that these are predominantly in the they are involving the brain stem. These hyperintense signals involving the brain stem and the there is no evidence of tonsillar herniation.
Yes.
Uh,
What's your diagnosis?
yes. Sir, fine. It could be due to any metabolic disorder
Okay.
or
What else?
I would also like to see the diffusion weighted images.
This is the diffusion.
So no internal diffusion seen. Yeah, there is no internal diffusion restriction seen. So, I sir, it could be due to any metabolic disorder or any demyelinating disorder.
Okay.
Um,
Like
um, uh, like Adam or
but the patient didn't have fever or any history of previous infection. He just have acute headache.
sir, the superior sagittal sinus appears normal, no evidence of thrombosis. Um,
See, you have something here, but you are stuck.
yes.
You are stuck now in your diagnosis. Could you have a general look in the rest of the exam? You may find any other finding that can complete the picture and يعني clear up in your mind the diagnosis.
I'm trying to look for if there is any evidence of any internal cerebral vein involvement, or
The answer in this
as it
slide.
can also cause.
The answer in this slice. What happened?
So there is an hyperintense signal involving the right midbrain.
What else?
Uh, there are some subtle signals also seen involving the temporal lobes.
What else? What happened here?
So, okay, there is thickening. There is thickening of the optic chiasma.
What does it mean for you?
Sir, it's a demyelinating disorder that is also involving the optic nerve.
Demyelinating? What else? What else? What else?
Sorry, sir.
You have, let's wrap up what you find. You have multiple scattered, mainly basal ganglia and thalami, signal abnormality, and tactile plate bulging and signal abnormality, and bilateral cerebellar hemispheres, and bilateral expansion of the optic chias and optic nerve. Equal?
Okay, so
What does it equal?
yeah, yeah. So these are the multifocal, sir, what we say, the hyperintense signals that occur in maybe in any syndromic
Yes. What is the name of the
disorders like.
syndrome? Yes, it is a syndromic. What is the name of this syndrome? This is the most common phacomatoses.
Yes, sir, NF1.
Yes, excellent. Thank you, doctor. It also was a difficult case. Why? Because I gave her a very misleading history. When I told her the patient have acute headache, and by the way, it is acceptable. Why? NF patient, neurofibromatosis patient, may have acute headache, and he will come to you for brain MRI or CT. And finally, it was a psychological or a psychic headache. Okay. And finally, you find all of this. Really, really, until here, it looks like encephalitis, looks like something vague, metabolic, but search for any helping sign. Again, this all abnormal signal here may mean anything, metabolic, encephalitis, even Down. Till now, it is not a characteristic for NF1. Okay, but this bilateral optic nerve glioma is pathognomonic because this tumor, pilocytic astrocytoma, bilateral, pathognomonic. Okay, and
Okay.
this one looks like also tactile plate glioma. So my advice for all of you, when you are stuck in a diagnosis for something like this one, search, look at the orbit, especially the orbit, to rule out NF1, and look at the greater wing of the sphenoid, or look at any other masses, or look at any subcortical abnormalities, or subependymal calcification to rule out tuberous sclerosis. Okay? So the golden advice of today, when you have something vague like this, don't speak much about it. There are multiple scattered basal ganglia and midbrain and postcerebellar signal abnormality. Some of them are expanded Okay? There are high T2 and flare. Okay. Don't talk and talk and talk about the same area because you will not get a proper diagnosis. What should you do? Look subcortical, look subependymal, look at the orbit. Okay? Why? You
Yes.
must find something in these three areas to diagnose any phacomatoses. If you didn't find anything, yeah, for example, if this case didn't have this bilateral optic glioma, it is acceptable to put any metabolic or any encephalitis within the differential diagnosis. Okay, or even this patient is 13-year-old, maybe other diseases. Again and again, when we find any basal ganglion signal abnormality like this, before telling or before confusing, go subependymal, go subcortical, go to the orbit. Thank you so much. Or even to the CB angle for NF2, but if NF2 will not present it with this fuzzy focal area of signal intensity. Thank you, Doc.
Yes, sir.
Welcome. Are you ready?
Yes, sir.
I don't know if this a tricky case or not. What do you think? This is a tricky case?
Sir, I don't know.
Okay, this is a 5-year-old male patient presented with altered sensory sensation and episodes of seizures. Go.
Uh, this is the flare image of a 5-year-old patient who presented with altered sensorium and seizures. And in this case, I can see that there is signal abnormality which is involving the bilateral basal ganglia.
Yes.
There is also it is showing flare high signal intensity in the center with some iso signal intensity on the periphery. I can also see some other flare high signal intensity foci which are noted in the left caudate nucleus, in the right medial temporal lobe, and in the left posterior occipital lobe. And I would like to see
1 second. Yes. Yes, yes.
I would like any other sequence available, like T2 and sagittal sequences as well.
Okay, this is T2.
Okay, again, I can see that there is signal abnormality which is involving the, okay, I can also see that there is signal abnormality involving the bilateral cerebellum as well as the basal ganglia. There is some swelling of the sulci as well, and edema is also noted. So, in the 5-year-old patient, I would
Yes.
like to think about any history of infection or fever in the last week, because this would most because of the involvement of the basal ganglia and
Yes.
the logical appearances. I'm thinking that this might represent Adam, and I would like to inquire about the previous history of infection.
Look here,
And
please.
I
Look here, please. What happened?
yes, um, sir, there is okay, it is T1 weighted image, and
Yes.
I can see that the signal abnormality in the basal ganglia is showing T1 hyperintense signals.
Yes. What does it
So,
mean?
sir, it is involving bilateral basal ganglia, and it is not predominantly a vascular, like it doesn't look like to be a vascular territory with well circumscribed focal hemorrhages. So I'm thinking that there might be some hemorrhagic conversion in the disease process which is involving the bilateral basal ganglia. I can remember there are some variants of the demyelinating disease which may present with hemorrhage.
Could you think?
Other
Could you think?
uh,
Look here also. Could you think this is possible?
Sir, I can see that there is signal abnormality also involving the bilateral cerebellum. and it is showing that hyperintense signal on the periphery as well. I would like to I would like to consider the possibility of cerebritis, encephalitis, or any infection which might be involving the meninges as well as the cerebellum. And
Which type
I
of
would
colitis or encephalitis? Which type?
uh, Sir, the appearance on the T2 weighted sequence it was appearing as very dirty T2 signal. So I'm thinking that this might be because of tuberculosis, and I would like to investigate it further. Okay, I can also say that there is a pacification of the bilateral mastoid sinuses and with T2 hyperintense signals. So there may be some kind of infection which is causing these abnormalities. I would also like to see the diffusion weighted and the post contrast images if available.
Look here, doctor, please. See, this is T1. Okay, T1.
Okay,
You have, what is this?
so high signal
What does it mean?
involving
T1.
some maybe some proteinaceous contents or some hemorrhage.
Yes. Okay. Okay. In flare. See? What do you think?
So I think that it is
Bilateral,
still high. Yes,
bilateral,
bilateral.
nearly symmetrical thalamic and cerebellum and right basal ganglia. What does it mean for you? Does all of them have the high T1 signal? Look, I think
And
all.
few of them have, yes.
No,
Oh,
most.
oh yes.
What does it mean
Okay,
for
okay.
you? What does it mean? Give me some differential diagnosis.
Sir, okay, so all of them having T1 high signal intensity could be related to some sir drug-induced changes.
In patient 5 year olds, he's still a clear man. He will not abuse drug now.
Yes. Sir, mm, so I can't think of anything else which might be causing a high signal intensity in all these areas
What is
because they
what is the most common pathology to cause high signal in T1 here, surrounded with
uh,
T1? Yes.
sir, hemorrhage is the most common.
Okay, but it is multifocal and non-territorial. The patient didn't have high blood pressure. Okay, so it's
Mm-hmm.
not hypertensive.
Okay,
This
so could
patient,
be.
mm,
Mhm.
yes.
Um, Sir, with the history of seizures, I can only think that there might be some uh, tuberous sclerosis kind of thing in this patient,
But
but
tuberous
the
sclerosis will not have this
not
hemorrhage
have. Yes,
because
yes,
look,
sir.
look here. This is acute hemorrhage.
Oh,
Acute. Why? Subacute because it is high T1, high T2, high T1, high T2. This is subacute hemorrhage. Okay. What
okay.
what else?
Mm. Sir, subacute hemorrhage in a 5-year-old patient presenting with seizures.
Yes.
Uh, I'm thinking that might be some kind of hemorrhage, some kind of um
Yes.
so vascular abnormality is less likely
Okay.
because
What
it
else?
can,
What else?
sir, it can be any underlying multifocal neoplastic etiology like lymphoma or anything.
Very unrare in this age group. Look here. Look here. The sagittal sinus or all of them are signal void. Clear. So we rule out inferior or
Yes.
inferior, mainly inferior sagittal sinus or internal cerebral vein thrombosis.
Oh,
What else?
yes, sir.
Multifocal, multifocal
Mhm.
hemorrhagic signal abnormality. In a child, what comes in your mind? Malignancy is not a logic, not logic. Okay, venous Dural venous thrombosis, we exclude it. What else? I think also artery of Percheron is not a possibility. Very
Yes,
rare.
because it is not such single territory, it is multifocal.
Yeah, I will help you. You mentioned something about this one. Despite this is not true, but what does it mean for you? What does?
Sir, it means that there is inflammation of the sinuses involved in the mastoids, and that means
Yeah.
maybe some kind of, yes,
Of what?
mastoiditis or infection.
Okay. So what's the possibility happened here?
Sir, maybe the hemorrhagic encephalitis, because
Yes. Very simple. This is the hemorrhagic encephalitis. But we are not, this case, we are not familiar to this type of case. What happened here? Thank you, doctor. Don't worry.
Yes, sir.
This is unfamiliar case. Okay, what happened?
Yes.
High T1 lesions in very young patient, 5 years, 5-year-olds, multifocal. No, sure, not related to hypertension or venous thrombosis. Okay, in young age like this, we should thinking about hemorrhagic encephalitis or necrotizing encephalitis or Japanese encephalitis. Very easy, very simple. But the trick of this case is that this is non-common case for us. We are not familiar to encephalitis. Okay, next candidate. Next candidate. Hello.
Yes, we
Hello,
have
sir.
two backups. Please proceed.
I'm the first backup. Assalamu alaikum.
Wassalam. 1 second, doctor.
So I've been.
1 second.
Yeah. Sorry.
No problem. Don't worry. We finish this one. Let's remove. Okay. Go on.
Sir, may I please know the age of the patient and if any history available?
Okay, 40-year-old male patient. Okay, presented with 1 second. Psychological disorder.
So I've been presented with multiplanar, multisequential MRI of a 40-year-old male patient demonstrating significant deformation of the left cerebral parenchyma, where there's paucity of the gyri. That is a pachygyria with ipsilateral dilatation of the left occipital horn associated with periventricular flare white matter hyperintensities likely representing gliosis. I cannot appreciate any abnormality within the cerebellum or right cerebral hemisphere. Multiple subcortical hyperintense signals are also appreciated in left frontal lobes and left paramidline mid-sagittal location with few cystic changes likely in cephalomalacia. The
Yes.
ipsilateral.
Yes.
I'm looking for the sinuses. They do not appear to be enlarged. The ventricular chain otherwise also appear to be unremarkable.
Yes.
I would like to, yes, thank you. So on this T2 coronal sequence, I can appreciate there's left-sided cortical atrophy with encephalomalacic changes and vacuum dilatation of the occipital horns of the left lateral ventricle. There are also diffuse subcortical T2 hypointense signals likely presenting calcification that I would like to check on any prior CT imaging if available. These are the GRE sequences where these T2 hypointense signals are giving blooming artifact representing subcortical calcification of this area. So this area likely represents lobar atrophic changes with pachygyria, calcification in cephalomalacia, and exvacuum dilatation of the occipital horn of left lateral ventricle. It may represent prior insult to this area leading to all these changes, or it can be lobar unilateral left-sided atrophy, which can be congenital. I would like, in this case, I would also like to check with any prior imaging if it has been present since before, or the patient is known to some congenital abnormality.
So what's your final diagnosis?
It's lobar, so but subcortical calcifications with it.
What is lobar?
Atrophy. My differential would be first differential would be
Second, one
asymmetrical
second.
unilateral. Sorry,
1 second. What's lobar?
it's
What do you mean?
left parieto-occipital region is only involved. Frontal region is not that commonly involved.
Okay. Could you have a look here at the player, please? What happened here?
So the changes are there on the left side diffusely, but predominantly involving the left parieto-occipitotemporal region. Frontal lobe is not that
Yes, yes,
equally involved.
yes. Did you find anything else?
Multiple subcortical flare and T2 hyperintense signals with gyral abnormalities.
Where? Where?
Bilateral asymmetrical frontoparietal regions and occipital as well.
Excellent. Look
The
here.
deep gray matter appear.
Look here.
Yes.
Could you detect anything?
Multiple subcortical T2 hyperintense signals, frontal, occipital, but diffusely, and also subependymal nodules in the
What does
ventricles.
it mean for you?
Tuberous sclerosis.
Yes. Tuberous sclerosis.
Tuberous sclerosis with cortical tubers, subependymal nodules, but not associated with any abnormal subependymal astrocytoma. The the left-sided temporoparietal abnormal signals. So I'll screen the patient for other stigmata of the tuberous sclerosis, including screening for the cardiac rhabdomyosarcomas and abdominal ultrasound and CT abdominal pelvis to look for renal abnormalities, AMLs. I will immediately inform the referring physician, and I'll also request for them for family screening.
Yes, thank you, doctor. What happened in this case? One of the other tricks. What happened? The examiner gave you a very misleading, little bit unclear history, okay? Because if he told you this patient has mental retardation, seizures, CPAM, خلاص, from the history you will diagnose immediately this is tuberous sclerosis. And even the image itself really, really very suggestive of some ischemic changes here in encephalomalacia like our candidate do, exactly. Any one of us will be presented with this case, he will start with describe these areas as post ischemic changes and encephalomalacia like this, all of this. But don't trust the examiner when he give you something very clear. If you have a general look like this, you will find that there are here and here subcortical bright signal, bilateral. And this is very pathognomonic of tuberous sclerosis. Okay, my colleague. So when you are giving a case, especially very, very obvious, simple diagnosis like this, be sure that are something will complete the scenario. Be sure that it may be syndromic case. It may be a systemic case, whatever. What should we do? Like I told you before, look at the subcortical, look at subependymal. If you didn't find anything, look at the both optic nerves. Okay? At least you will find something. Okay? Also look here at the basal ganglia because sometimes you have abnormality, very obvious abnormality peripherally, and another finding in the basal ganglia will complete the full picture. Second, this is a subependymal, or this one, this is very dark one, very clear here in gradient. Where is the gradient? Anyway, it is a calcification here. Subependymal here, this one. Marked subependymal low signal or blooming artifact. This is calcification. Okay, so our case was tuberous sclerosis. And by the way, this volume loss, this previously, يعني, or what our candidate described as encephalomalacia and ischemic changes, not mentioned here in the radiopedia at all, not mentioned. Okay, this is what does it mean for us? It means we should take the whole picture, the whole scenario of the image. One of our candidates sent one comment on the previous case, this one. Okay, sure, it is a dengue fever or a dengue encephalitis. Okay, I'm very agree with you. But the most important here to describe it as a hemorrhagic encephalitis. Why? Because a hemorrhagic encephalitis is a wider term. Under it, you can see the differential diagnosis of dengue encephalitis. Number one, Japanese encephalitis. Number two, necrotizing encephalitis. Number three, Adam. But Adam is not commonly associated with hemorrhage. Okay? So if at least you told the examiner it is a hemorrhagic encephalitis and give him the three common differential diagnosis, number one, Japanese encephalitis, or necrotizing encephalitis, or dengue fever, he will be very happy. Why I'm telling like this? Because inside the exam, really, yeah, you are struggling to answer, to collect information, to scroll, to talk, and also to listen the examiner. Okay, so it is better to think holistically. Okay, somebody asked, is this case the case before? Maybe Stag Weber, this one. I think due to the presence of this subependymal nodule, the diagnosis must be only tuberous sclerosis. This one. Presence of this subependymal nodules close the way in front of other differential diagnosis completely. Without these nodules, you can diagnose this area as post-ischemic changes, maybe Stag-Weber, maybe. But presence of this subependymal nodule is very pathognomonic to tuberous sclerosis. Besides, sure, this also subcortical tubers, but this one is pathognomonic. The only differential for subependymal nodules is the heterotopia, but the whole picture of this patient is not the picture of heterotopia. Thank you so much for all of you, my colleagues. Thank you for our coordinator. Let's meet next week. Goodbye.